All right, so part of the lecture today, we want to look at the CT scanner components and their roles. We want to look at how the images are generated, understand a little bit about radiation exposure and the as low as reasonably achievable. We want to look at some indications for CT, look at contraindication safety considerations, and then also look at CT versus MRI versus X-ray. So starting off with the CT scanner, we've got a gantry. I've got some pictures coming up, but essentially it's your circular lesion. So we talk about it as the donut. And that contains your X-ray tubing, it's an X-ray tube which is rotating at high speed. You've got your detector array, and these are detectors that are measuring your transmitted X-ray rays. You've got your collimators, exactly the same as with the normal X-ray, just making sure that you control the beam. And there's slip ring technology, which allows for this continuous rotation, particularly when it comes to helical scanning. Your X-ray tube, again, exactly the same as an X-ray, produces your high energy photons. With a CT scan, this is typically 80 to 140 kilovolts. You get a rapid heat load and dissipation that's required because of the amount of energy that's being produced. We have the focal spot, which determines your resolution. So the smaller the focal spot, the higher the resolution, but the higher the heat. So there is some limitations when it comes to that. Your detector array, very similar to the MRI setup, converts your transmitted X-rays into electrical signals, and then that assigns them a digital value. There's two different ways. So previously we used to use gas ionization detectors, which is now old technology. These days we use scintillation detectors, which is in all our modern machines. And the key performance factors that we look at is the efficiency of the machine, afterglow, the speed of image acquisition, and the dynamic range that we're able to achieve with the scanner. And then we've got the patient couch. So these are pretty much the same in all your scanning type equipment. It's motorized, it moves with sub-millimeter precision, and it also allows for helical or continual axial step and shoot modes. So it slides in and out of the donut. We can control exactly which body part is being exposed. It can move quite slowly, it can move quite fast. They normally got a little bit of a concavity to it, so the patient sits quite nicely in there. But it does mean that we've got limitations as to positioning. So we need to position someone supine, or we can position someone prone. We do very occasionally position someone lateral lying in the lateral decubitus position, but that is very unusual for us to do that. It's not really set up for that. But occasionally people do have disabilities or issues where we do have to become a little creative with the positioning. And then we normally support them with pillows and what we call foam is one of the specific elements that we use. So your computer and reconstruction system takes all this raw data that's been assigned digital values and it reconstructs the images. So there's algorithms that work on two basic ways. There's the filtered back projection and there's the interact or the iterative reconstruction, which allows a lower dose, but with improved image quality. So we are moving now towards the iterative reconstruction, but occasionally we do need just high quality images that does come with, rapid acquisition, which has the trade-off with radiation exposure. So this is what it looks like. So you've got your data acquisition system that sits right at the top over here. This is your gantry, is the round bit, and then these are your detector rings that are surrounding, and then your X-ray tube, which actually spins all the way around here. You've got your deflection coils, your focus coils, and then your electron gun. And then this is your scanning electron beam that comes through here. So essentially, this is the donut that we talk about, and the couch goes in and out. So it looks very similar to an MRI scanner on the outside. The difference is that this is ionizing radiation compared to the MRI scanner, which is based on hydrogen atoms. And this is what it looks like, because although what we've got here is just the raw elements, it's all covered with housing and with frames. So this is what it looks like when you actually see it in the scanning room. So this is your reconstruction table that sits towards the back. Often this sits in the control room. Then you've got your gantry, which is all your bits are underneath, so that your detection array is underneath there. Your X-ray tubing is there as well. And then often up here, this is your modality. So often this is where we have our image acquisition, but there's often cameras here. There's various other sets that we use for things like delivering dye, sometimes music, and there's a lot of customization that happens with a lot of these machines. So it's very high tech these days compared to what we used to have 20 years ago. So how the images are actually acquired is that it starts off here with your patient on the table, and your patient then goes into the donut, which has your X-ray detectors and your X-ray tube. And essentially your X-ray tube and detectors measure the attenuation differences of beams that get fired in multiple different directions through the patient. What happens there is that you get acquisition of the images, you get a data signature that gets applied to them. These then go into the operational computer, and then you get your image generation through your software and through your computer systems that you've got. And then your operator sits over here and with various software is able to optimize the images in terms of the contrast, get different sequencing. We have different windows. So with MRI, we used to have different protocols. With CT, we've got different windows because we're using Hounsfield units. So we can adjust the Hounsfield units to show us certain tissues in more detail. And the operator can also control how the slices are actually presented. So making sure that, you know, if we're looking for a true orthogonal, we can get a good 90-degree plane to the image that we're looking at, both in the longitudinal, the axial, the horizontal, the coronal. Depending on which image that you're looking at, the operator can fine-tune that quite nicely. So there are different ways of acquiring image. So we talk about image modes, or acquisition mode. So there's the axial step and shoot, which is essentially the patient is just there and it spins around the same trajectory and it moves all the way down. We then get the axial without any table motion, which is where the image just spins, but the table actually stays flat. With the axial step and shoot, it's spinning and the patient is moving. And then we get the helical, where the patient's moving and everything's spinning, and we actually get a very, very rapid sort of spiral effect CT scan. So when we've got someone who's in a really bad way, trauma situation, we literally need a scan in under a minute. We go for a helical scan and we can run a patient through that very quickly with a full body. And compared to an MRI scan of the lumbar spine can take 20 minutes. A CT scan essentially takes a couple of seconds, maybe a minute at the most. So if you've got someone who is, you know, needs resuscitation, is in a very bad way physiologically, or is in a lot of pain and can't lie still, sometimes we make the decision to go with CT scan rather than MRI scan. And again, I've just put a little bit more detail here. So you get the non-helical CT. So this is where it is just spinning around in the same place. Then you get the helical, which is the spiral. And then you get the multi-slice CT. So a little bit of an explanation for each of those there that you can go back to with a picture to remind you of how that works. So your axial, your step and shoot CT, the table moves, you get a scan, it stops, table moves, you get a scan, and then it stops. So this gives you a high quality image. It's used now not as commonly as the other sequences that we have, other than cardiac CT. It's very good for that. And there are some other special situations, but really it's cardiac. That is the big one that we still use the axial CT for. The helical spiral CT is where the table moves continuously as the gantry rotates. And this is producing a continuous data, and it's almost in most protocols these days. So the benefits for this is that it's faster, there's a lot less motion artifacts, It enables multiplanar reconstructions, and it also enables angiography as well. So angiography is where we put a tube into the person's vein, we put contrast into it. So not only are we seeing the anatomy, we're also seeing where the contrast goes through the veins as well. And then we get the multi-detector CT. So this is a modern system, and then there's different slices. So 16, 64, 128, 256, 320 slices. And essentially, the more detectors they have, or the image has, the thinner the slices can be, which means that the better resolution. And this is when you're looking for those very small anatomical differences. You're looking for very small tumors. We don't have massive capacity. Excuse me. So in our hospital, we don't have a 320 slice. That's more for sort of research basis, but some of the big teaching hospitals have got very, very, very sensitive multi-detector machines. And then we've got our reconstruction. So the raw data comes along as these digitally assigned kernels, and then it gets processed through the actual data processing in the computer system with the algorithms. And this is where we talk about windows. So we've got different windows. So we've got the soft tissue, we've got the bone, and we've got the lung. And these windows are essentially constructed or set up to optimize the tissue that we're looking at. And that is so we can get that detail, we can look at the anatomy, we can look at the measurements, and we can look particularly for things like bleeding. So if someone's had a big injury to the abdomen, there's a lot of blood in the abdomen, and we're looking for bleeding sources, CT scan is incredibly good. It's also very, very good at looking at the lungs and looking at the chest. So things like cancers, particularly small cancers on the chest and the mediastinum, very, very good with CT scan. And CT scan is measured in Hounsfield units. So depending on the Hounsfield unit, there's a different value that then gets applied in the actual algorithm that we get. So your common ones, air is 1,000, fat is 100, water is 0. And then you've got everything in between. Oh, excuse me. I was operating late last night, so sorry for the yawning. Okay. And then a big thing is radiation exposure. So a lot of this is about seeing it in context, because we are taking a person and just walking around the world, we're exposed to radiation, background radiation. So we need to see this in terms of, if we're now going to request some imaging on a patient, we're going to put them into a scanner and bombard them with radiation. We need to work out how relative that is to what we would be exposed to on a daily basis. So if we actually look at a chest X-ray, we're looking at 0.1 millisieverts. If you were just flying for 10 hours in a plane, you would be exposed to 0.04 millisieverts. So essentially, your chest X-ray is not to be ignored. It is actually a fair dosage of radiation. But if you look at a mammogram, 0.4, then lung cancer screening up to radiation, which is 3 to 5 millisieverts. So that's just walking around and existing. You would be exposed anywhere from 3 to 5 millisieverts across the course of a year. Whereas if you put someone in a diagnostic CT scanner, you are giving them 7 millisieverts straight up. So this is almost a year's worth of radiation walking around. So you are accelerating the radiation exposure by a year. So you can imagine now, if someone has multiple CT scans because of follow-ups or because of investigations, these are starting to get fairly significant numbers that we have to pay attention to. And then other annotations that you may see are dose per slice, dose for the entire scan, and then your effective dose, which is the risk estimate. So you'll see these in different contexts, but that's what it means. So dose per slice, dose per entire scan versus your risk estimate. So your typical effective doses, so this will be in millisieverts for various body parts. CT head, 1 to 2 millisieverts. CT cervical spine at 3 to 6 millisieverts, so we're heading on to a year's worth of radiation there. CT thoracic spine, 7 to 10 millisieverts, so nearly 2 years. CT lumbar spine, 5 to 8, so just under 2 years. CT abdomen pelvis, 8 to 15. And background radiation per year in Australia, I'm not quite sure what it is like in Malaysia, but certainly in Australia, is approximately 2 millisieverts per year. So it is slightly variable in the world depending on where a person is based. The ALARA principles stand for as low as reasonably achievable. And this is by the Australian Protection Against Radiation Safety Council. So you will have something similar in Malaysia, which will be a Radiation Safety Council, and they will have specific legislation about what is acceptable to expose a person to and what the radiation standards are for the institutions. So the ALARA principles are, we have to justify the scan. So you can't just sign someone up because you just feel like it. You have to have a reason. The person taking the scan has the duty to optimize the dose, the modulation, and the image acquisition algorithms. You want to minimize the scan length, so you just want to do what you need. You want to avoid repeating the scanning, so you want to make sure you get a good shot the first time. And that also means you need to be clinically very aware of why you're requesting it and that you're requesting the correct scan for what you're looking for. You want to also use shielding as appropriate. So if you're not exposing the neck, if you're looking at the chest, you want to cover the gonads, you want to cover the thyroid. But in some cases, we're not actually using shielding anymore because sometimes that can give us artifacts over areas we are interested in. And even though we're trying to do a good thing and protect someone by covering them, by having to then repeat the scan in order to see some stuff that was missed means that we're actually exposing them to more radiation, which is sort of goes against what we were trying to achieve in the first place. So certainly in our unit, we've stopped using a lot of the shields with the preference that we use as low dose as possible, but we get the best scan the first time. So when it comes to communicating the risks with patients, I like to use relatable language. So this is where it's important to say, this is the equivalent of walking around outside for a year, or this is the equivalent of taking a short plane flight, or this is the equivalent of another procedure, so that patients have some context. What you want to do is you want to avoid causing anxiety in the patient. So some patients come in and are pretty anxious about the radiation exposure. And what you want to do is you want to emphasize the diagnostic value and also that you have a good reason. You don't want to just be having a list of procedures that you just request and then you never actually go back and use them for anything useful.